So, Chairman, ladies and gentlemen, first I would like to thank for the invitation. Unfortunately, we have a computer problem, so I cannot show you a video, but I think that is not the problem. I would like to discuss with you now the role of endoscopic resection in the whole concept of treatment of Barrett's esophagus. And I think you have heard today a lot already about Barrett's esophagus. I think we can say also with regard to the presentation of Jack Bergman that there are two consensus, and the consensus is that only neoplastic changes have to be treated because the cancer risk is relatively low per year for the patient. And the second point is in the last 10 years, we know that we have to achieve a complete eradication of the whole Barrett segment because our competitors, the surgeons, also perform a resection of the whole Barrett's segment. Endoscopic resection is the major part of the treatment, and first it is a diagnostic measurement because we exclude a deep submucosal invasion because these patients need to undergo surgery, and you have heard about the concept today that usually we resect the visible lesion of the Barrett's and the remaining Barrett's is treated by radiofrequency ablation. Now I want to focus on the role of endoscopic resection. And in the last 10 years, the techniques have developed, and you see here that the endoscopic piecemeal resection technique is a very safe technique. This is a prospective trial from Amsterdam. You see in 1,060 resections, there was no perforation and only a delayed bleeding rate of 2.1%. What about the evidence-based outcome data? There is the largest trial with 1,000 patients with intramucosal cancer from the Wiesbaden group, and these data show that there is a complete remission in 96% of the patients, and not only in the short-term follow-up, but also in the long-term follow-up you have a complete remission rate of 94%, and the major complication rate is only 1.5%. So you may think everything is fine, the results are very good, but I also want to discuss with you some new aspects and also some critical things. The first question is now, how far can we go with the endoscopic resection? Is the endoscopic resection only limited to the mucosa? We have now new data available which show that we can extend the curative endoscopic resection also to the submucosal space. And the data show if you have a tumor infiltration up to 500 micrometers in the superficial layer of the submucosa, endoscopic resection is also a safe therapy in case there is no lymphovascular invasion and if it is only a well-differentiated cancer. Second question, how shall we deal with poorly differentiated cancer? In this study of L, it has been shown that these patients supposed to have not a higher rate of lymph node metastasis, only the local recurrence rate is higher. However, I think these data are not enough to say that we can also treat poorly differentiated cancer. I think if you have a patient with poorly differentiated cancer, it's still an indication for surgery. Now we have to discuss critically which resection technique we should use. You know, we can perform endoscopic piecemeal resection, which is relatively easy to perform. However, we can also perform an endoscopic submucosal dissection. And the situation is somehow there are two groups of endoscopists. One group is saying we only need the piecemeal resection, other group we need ESD for every patient, and I think the truth is somehow in between. And I want to bring up now some points with this background. When we perform endoscopic piecemeal resection, we can have the situation that we have cancer in more than one piece and that we have a positive lateral resection margin. And I want to show you a case of the daily clinical practice. This is a patient, he has an early Barrett's cancer, and from the beginning you see that the lesion is larger than 1.5 centimeters. So if you perform piecemeal resection in this patient, you know that you get a situation like that you may receive a clean horizontal margin. However, the lateral margin will be positive. Question is now, is this accepted if you have several pieces like that? We have to say, from the current data, and these data are all data with regard to piecemeal resection, it seems to have no influence on the long-term outcome. And also with regard here to this consensus meeting in Amsterdam, this situation is accepted for a curative endoscopic treatment. However, I think because we have different types of endoscopists and ESD is somehow very strongly propagated, I think it would be good if we perform a specific sub-analysis of exactly these patients with a lateral R1 resection margin or cancer in more than one pieces in the patients of the Euro 2 study, because we know this is a very interesting collective, it's prospectively randomized, it is prospectively collected, and think that would be a very good sub-analysis for the discussion with regard to this issue. I have checked the data with regard to this issue, and you can find only in one paper in the small print something about this problem. In the L study in 2008, it is written that 35% of the patients had a positive lateral margin. This has no influence on the long-term outcome. However, on the other hand, the authors also conclude that piecemeal resection is an independent risk factor for recurrence of the early Barrett's cancer. So somehow I think we have to discuss this issue in the future. And I think one very important point is to discuss the quality of the piecemeal resection. Because if you perform piecemeal like that, then you have remnant ridges and the quality of the EMR will be not good. Fortunately, I cannot show you now this video, but I think it's no problem. I think with a duet system, you have a very good opportunity to perform really a high quality EMR with no remnant ridges. And the important point is that you place the cap when you perform the second and third resection into the area of the previous resection with an overlapping. And if you perform this overlapping, then you get clean resection areas like in the ESD. And I think this is the most important point for a high quality EMR which has no recurrent cancer in the follow-up. Another question is, I've mentioned to you that it is now also possible to curative treat patients with a superficial submucosal invasion. But now we have to ask ourselves, if we perform piecemeal resection, how thick will be the specimen? And this is also a very interesting Amsterdam data comparing the different piecemeal techniques. And I think here's a very important point, the thickness of the pieces. And you see the thickness of the pieces, the medium value is 1 or 0.8 millimeter. However, the lowest range is 0.5 in this with the ER technique and 0.55 with the MBM technique. So if we accept an infiltration of 500 micrometer, then Michael Feet will get a problem to really tell us if this has been an R0 resection or not. So I think in such a situation where you suspect a submucosal invasion of the cancer, these are the patients which should be considered for an ESD treatment in the Barrett's. And I would like to show you an example. This is a patient here. He has a compact lesion where a submucosal invasion is suspected. I think these patients should undergo endoscopic submucosal dissection. Now the question is, how are the results? As you know, Japanese endoscopists are leading with regard to the ESD technique, but in Japan, Barrett's is very rare. And we know as European endoscopists that the ESD technique, because we have not so much practice because of the low incidence of gastric cancer. How are the results? And I would like to show you here a very interesting study from Horst Neuhaus from Düsseldorf. He has treated a Barrett's patient with ESD, and the results are quite interesting. I think the procedure duration and the complication is acceptable, 75 minutes, and the minor bleeding rate is only 6%. What is interesting that it is difficult to get a high complete resection rate of the neoplasm. The R0 resection is only 40%, and especially in a high percentage of the patient, the horizontal margin was not free. However, if we have a look at the complete remission rate of neoplasia, this rate is quite high with 95%. Another point is what we have to discuss: if you have Barrett's cancer, an early cancer in the area of the squamous cell epithelium on the borderline, the question is how far does do the malignant changes go beneath the squamous cell epithelium? This is an example, a patient with an early cancer. However, you see here an extension of the cancer under the squamous cell epithelium. And these are the histological slides here. You see cancer also subsquamous. And there is an interesting paper from the Hamburg group, and they found out that you have subsquamous intestinal metaplasia in more than almost all patients. And the mean length of this subsquamous intestinal metaplasia is about 3.3 millimeters. So if you perform a resection of a lesion in this area, it is very important that the resection should be extended at least 1 centimeter into the squamous cell epithelium. Let me come now to a last point. I've mentioned that I want to talk about the role of the endoscopic resection in the whole concept of the Barrett's treatment. And usually we perform first endoscopic resection, then we perform radiofrequency ablation, and then we have sometimes remnant areas of Barrett's. And in this situation, the so-called escaped endoscopic resection plays an important role. The video unfortunately doesn't work, but doesn't matter. You see here new squamous cell epithelium, and this is an incomplete area from radiofrequency ablation, or sometimes you can also have the problems of buried glands. I think in these situations, endoscopic resection is still doable, also if the patient has the new squamous cell epithelium. And we have here also an example of a patient who developed an early cancer in this area of the new squamous cell epithelium. Also, these patients can be treated by escape endoscopic resection. Finally, I would like to show you our data from Zurich, and I have to mention these are not data of a prospective trial, but these are data of the daily clinical life, and we have treated in the last 5 years more than 100 patients with early malignant changes in Barrett's, and from our patients it is interesting to note that compared to some studies, we have a lot of patients nowadays with a long segment Barrett's esophagus. 10% of the patients had Barrett's more than 10 centimeters. And if you want to see the role of endoscopic resection, almost 90% of the patients got endoscopic piecemeal resection. And here you also see the role of ESD. Less than 5% of the patients received endoscopic submucosal dissection. Almost 60% of the patients got radiofrequency ablation, and you see here the role of endoscopic resection. After the diagnostic workup, the histology was upgraded in 22% of the patients, and it was downgraded in 6% of the patients. So this is the major role of the endoscopic resection at the beginning of the therapy. And when we have now a look up, at the complications, also we had no perforation. We have some patients with bleedings, but what we have noticed when we have patients with long segment Barrett's esophagus, endoscopic therapy is a very long therapy. Sometimes it takes more than 1 year. We need a lot of endoscopic sessions, and the escape EMR is very important because our goal is to get rid of the whole Barrett's. And we realized in 50% of our patients, we performed an escape endoscopic resection at the end of the therapy to get completely rid of the Barrett's segment after the previous EMR and radiofrequency ablation. And with regard to our results, treatment is finished in 77 of our patients, 77%, and I think we can compare our data with the just published data from Amsterdam, because we also had a complete free dysplasia rate of about 95% and a complete free rate of intestinal metaplasia of about 80%. So let me conclude. Endoscopic resection is the main part of the endoscopic therapy of early malignant changes in Barrett's esophagus. Endoscopic resection is primarily diagnostic. It's a safe and effective method. All visible lesions have to be endoscopically resected before a radiofrequency ablation is performed. The quality of endoscopic piecemeal resection is very important. We have some patients where we have an indication for endoscopic submucosal dissection, especially in suspected submucosal infiltration. From our experience, it's about 5% of the patients. And at the end of the endoscopic therapy, escape endoscopic resection after incomplete RFA plays an important role to finalize the treatment. Thank you very much.